Hi everyone, welcome again to JOSPT Asks, the weekly chat where you, the audience, get your questions answered. I'm Clare. I'm the Editor-in-Chief of JOSPT. It's really great to be chatting with you again this week. Thanks so much for making the time to join us. Today on JOSPT Asks, as I said, we're joined by Dr. Rich Willy from the University of Montana. Rich has got a very prolific research CV, and I'm sure that many of you will be familiar with his really wonderful, really clinically relevant work. So we could have chosen to speak about running injuries, we could have chosen to speak about wearable technology, but we've chosen to dive into patellofemoral pain today. And I'm particularly looking forward to this because Rich was co-lead along with Dr. Christian Barton from La Trobe University in Australia on the recently published clinical practice guideline on patellofemoral pain. And you'll find that in the September 2019 issue of JOSPT. It's up on our website as a free download. So today, I suspect there's also going to be a little bit of discussion of running and perhaps wearables as well that creeps into our discussion. So stay tuned for that. It's really a great pleasure to have Rich on JOSPT Asks today to share his expertise on managing patellofemoral pain. Welcome to the live stream, Rich.
Thanks a lot, Claire. I'm super excited to be here, and thanks to JOSPT for hosting this.
It's an absolute pleasure. I'm really looking forward to getting stuck into the questions today. So let's start by talking about some misconceptions. So what's the biggest misconceptions that patients have about kneecap pain, and what's the biggest misconception that clinicians have about patellofemoral pain?
Yeah, see, I think probably the biggest misconception, and I think this extends not just for patients, but also for clinicians, is that patellofemoral pain is a self-limiting condition. And what that means is that it'll go away on its own. And we see this a lot with adolescent athletes who have patellofemoral pain, perhaps starting when they're 15 or 16 years of age. They may go see their general practitioner or get some advice from a therapist. And they said that this is something that you'll grow out of. And we used to think that, but now more so what we're starting to discover is that if you have patellofemoral pain as a high schooler and an adolescent, that's going to extend then into adulthood. So this is a condition that doesn't really go away on its own. And if you do have patellofemoral pain and it doesn't go away initially with some initial rest, that you should seek some care for that condition. So I think some other big misconceptions would be risk factors. And so we used to think, for instance, that if you overpronated or you had very flat feet, that was a risk factor for patellofemoral pain. And now we know that it isn't. And in fact, some research is starting to show that if you pronate, it actually is a little bit protective against certain knee injuries. So other ones would be if an athlete is taller or if they have a higher BMI. Or if they have a certain structure, so if they have a high Q angle, that is a static Q angle, we used to think that those things were more likely to kind of set someone up to develop patellofemoral pain. But more and more now we're realizing that those are not risk factors, and structure in and of itself, and I think this is kind of a common theme that we're starting to see with a lot of musculoskeletal injuries, is that structure is not a very big risk factor for patellofemoral pain. So I would encourage clinicians that are tuning in not to pay very much attention to a patient's structure when they're discussing patellofemoral pain with them.
This is great. We're at minute 4 of our hour and you're already sharing wonderful clinical tips. So fantastic. How does one go about diagnosing patellofemoral pain in the clinic, Rich? What would be your suggestions based on the best evidence?
Yeah, so patellofemoral pain is a diagnosis of exclusion, meaning you need to exclude some other knee conditions. And but before we get to that, I think generally when you think about patellofemoral pain, the onset is insidious and gradual onset. So it's typically resulting from a large increase in overall workload for that person from a relative standpoint. So maybe they suddenly started doing too much too soon, and then they developed this patellofemoral pain, and then that patellofemoral pain continued on after that. So we typically see complaints with patellofemoral pain patients that they'll have complaints with descending stairs, sitting for a long period of time, or moviegoer's knee as it's more often called, and then also deep squatting. Tends to really cause a lot of pain in individuals with patellofemoral pain. We want to make sure that we're excluding some conditions, and conditions would include things like IT band syndrome, so Osgood-Schlatters would be another one, knee osteoarthritis, any sort of like intra-articular tibial femoral joint injury. Those are going to be kind of the main ones that we want to exclude. But generally speaking, patellofemoral pain is, you can reproduce it with resisted knee extension and by doing some deep squatting. And then the third thing that you kind of always want to do is doing some Peri-Patellar palpation. So kind of palpating all around that patellofemoral joint and see if you can elicit their symptoms.
And we're still in a bit of a lot of people under COVID-19 restrictions. So is that kind of Peri-Patellar palpation something that you feel that you could have a patient do themselves if you're doing, say, a tele-rehab consult?
Yeah, I think so, quite easily. I think if you're palpating particularly on the medial aspect of the knee, just inside that patella, and if you're getting right on that femur, you should have some sensitivity there often. So that shouldn't be that hard to do. But the other ones, like pain if you're sitting for a long time and doing some deep squats and experiencing some pain, I think that those things are pretty easy to do from a telehealth standpoint. So yeah, I think some things that we don't tend to worry too much about, as I mentioned earlier, was Q angle. So that's not really part of the diagnostic criteria for patellofemoral pain. We also, let's see, there's a sign that you still see sometimes, or you still hear people talking about, which is called the J sign, which is the patella looks like it kind of tracks like a J. And that's also not a defining feature of patellofemoral pain from a clinical aspect. Crepitus, or kind of noise and kind of a cracking knee, even though a lot of times people who have patellofemoral pain have that crepitus kind of sound, it's also not a defining feature of patellofemoral pain. So if you have that, or someone does have some like a noisy kneecap, that doesn't necessarily mean that they're going to go on to develop patellofemoral pain. And it also doesn't have to be present for someone to get diagnosed with patellofemoral pain.
So let's just briefly touch on the etiology or some of the things that might cause patellofemoral pain. Is this a biomechanics thing, or is it some kind of funky motor control thing? Where are we up to with understanding what's driving some of these musculoskeletal problems?
Yeah, that's a super question, and we actually don't really know what exactly causes patellofemoral pain. We can't point to just one single thing, so it's probably going to be a combination of things. Generally speaking, though, it's going to be someone who has rapidly increased their training loads recently, and so someone who is maybe running, 40 kilometers a week, and then suddenly they double that volume, that's going to be a really nice opportunity to develop patellofemoral pain. Maybe if you're doing a lot of like level running and then suddenly you start running a lot of hills, that'll also increase your risk of developing patellofemoral pain. One of the other things that is a real risk factor for patellofemoral pain is sports specialization. And so we know that adolescent athletes, if they specialize in sports, they have almost a 30% increased risk of developing patellofemoral pain. And that kind of goes along with all knee injuries, as we're starting to discover. Like Osgood-Schlatters, for instance, if you specialize in a sport from a year-round standpoint, you have almost a 400% increased risk of developing Osgood-Schlatters. So in general, that's just a good thing to avoid. But yeah, and I think anything that really increases loading on the patellofemoral joint is going to be something that might increase one's risk of developing it. Oftentimes we'll see it, at least clinically, someone might develop patellofemoral pain after they've had like a long period of relative rest. So for instance, right now, a lot of people are, because of COVID, are not getting out and being not as active as they normally are. And then maybe when they're local lockdown or quarantine restrictions get lifted, people maybe are going outside and doing a lot of running or a lot of hiking because you're kind of craving that outdoor activity, and then that's a large relative increase in their overall workload. And so I would suspect that a lot of people are going to be developing these kind of relative overuse injuries in the coming months.
So let's talk about measuring outcomes briefly. I know that we've got a ton of questions about management. I really want to get to the management questions and spend a lot of time talking about management. But I think before we get there, it's useful just to touch on what you might measure in the clinic. So what would be your approach in the clinic to measuring outcomes? What sorts of things are you focusing on measuring and looking at as markers of progress?
Yeah, so I think that the AKPS is the best questionnaire, which is the anterior knee pain scale. It's also known as the Kujala. I think I'm butchering that. I think it's a Finnish name. So that's probably the best one. I think you'll also see the lower extremity functional scale, or the LEFS. And then the other one that you'll see some is the KOOS PF, which is the KOOS score, or the KOOS outcome measure that's kind of tailored towards the patellofemoral joint. For me, I would probably favor that AKPS, particularly for the athletes that I end up seeing. The lower extremity functional scale there's a big ceiling effect with that, and that it asks questions like, do you have pain when you walk between rooms, and do you have pain when you roll over in bed, and things like that most people are not going to have too many problems with. So if you're dealing with an active population, I would encourage you to use that AKPS, and if you're dealing with more sedentary populations, maybe the lower extremity functional scale would be the way to go. As far as from a testing standpoint, I think quadricep strength is such a good kind of marker or metric of overall knee health, and so I would encourage everybody to be testing quadricep strength. And manual muscle testing is not really going to be sufficient with this population, so we need to be doing something with a dynamometer if at all possible. At the very least, if you can get your patient onto some sort of knee extension machine and estimate their 1 repetition max, and I think through doing like 4 or 5 repetitions, there are several formulas that are available to do that. I would definitely recommend that, but we really need to be very objective in our strength testing. And I know Lynn Snyder-Mackler was on earlier. I'm sure she talked a lot about that. But I think that the more and more that we can be objective in our testing, I think the better we're going to be able to serve our athletes. I think other important testing would be posterior lateral hip strength, so hip abductors and hip extensors. For me, I think that those are important, but the quadricep strength is far and away the most important one to be measuring.
And your hip strength, are you doing that with a handheld dynamometer, or what
yeah,
sort of?
Definitely.
Yeah,
I would definitely recommend. Oh, sorry.
Go for it.
I would say that I would definitely be using some sort of handheld dynamometer, and if you can, stabilize it with straps, because that's going to give you a much better measurement than if you're just holding that handheld dynamometer on there, because your strength or your size is going to really influence that measurement.
Yeah, and I think the other point to make, and I'm really glad you emphasized the open chain measure for quads, so in the leg extension machine, not in the leg press, because the leg press, as many folks will be aware, athletes can cheat a lot with the leg press and avoid using their quads.
Mm-hmm. Absolutely.
Cool. So I think we've covered some nice self-reported function types of questions. You've got the strength measure. Some folks are starting to think a bit more about the psychological aspect, and we're getting more and more research to support the importance or the impact of psychological factors on particularly recovery after in chronic pain conditions. So any recommendations, any research evidence that you can share with us about psychological outcomes in this population?
Yeah, so we're starting to do some work in this area. So the Tampa scale of kinesiophobia is a metric that we're using, and I don't know if there's enough evidence out there to say that it has some predictive ability yet with patellofemoral pain patients, but it does seem to be patients with patellofemoral pain do seem to have more kinesiophobia. We also know too that your score on the fear avoidance beliefs questionnaire, the FABQ, is also predictive of how long you will have patellofemoral pain. So there does seem to be a large kind of psychosocial component to patellofemoral pain, and so I would say if you do have access to those tools, and all those are freely available online, I would encourage you to start tracking those metrics with your patients. But again, we just don't know enough yet to say that there's, if there are cutoff scores or something like that with those. But going back to that idea of some sort of psychological kind of component of patellofemoral pain, I think that's really important, because I think a lot of patients are very fearful of knee pain, and that's really problematic, because the standard of care for patellofemoral pain is not rest, and it's exercise therapy. And if you're not loading that knee, you're not going to be able to recover. And so if you're fearful of doing that, that's going to really hinder your ability to recover from that injury. And we see that in the literature when we look at low back pain, Achilles tendinopathy, and several other musculoskeletal injuries. So I think that's really important. And I think also too that, I think as the evidence kind of evolves, I think we're going to see that there, of course, there are going to be people who develop patellofemoral pain that it goes away very quickly. And then there are going to be other people that develop patellofemoral pain, and then it becomes this persisting issue for them. And I think that the determinant there might end up being the psychological influence. So if you get knee pain, let's say you're a runner and you develop some knee pain, you're like, this just is what happens when I run. And then you continue to exercise. And as we mentioned, exercise therapy is what you want to be doing for patellofemoral pain. That person's patellofemoral pain may likely go away. But let's say you are very fearful of knee pain, and maybe you've got some your social circle, your family has told you, well, if you run, you're going to ruin your knees, and then you develop patellofemoral pain, and so suddenly you become very fearful of this knee pain, and you feel like you're ruining your knees, or maybe you've already ruined your knees, and then you're very likely not going to be exercising with the same intensity after that, and that's going to probably encourage this patellofemoral pain to stick around a lot longer than what we would like to see it.
Yeah, so I think it's that mix of, we're getting more and more research from other areas of chronic musculoskeletal pain, and what we also are learning about acute injuries as well. And we're all working in a biopsychosocial model, so I don't think it's a surprise that for some patients the psychological side of this is going to be a bigger factor, and for others it might simply be the quad strength or the load management, and getting that right is going to be enough.
Yeah, I think so, definitely. And I also think too, like how we talk to our patients about their patellofemoral pain, I think is very important. I think it's important for patients understand that we don't actually know the source of pain for patellofemoral pain. We have some ideas, but we do know that it's not the articular cartilage. Articular cartilage is aneural. So if you have patellofemoral pain when you're exercising, that doesn't necessarily mean that you're ruining your cartilage. And in fact, when we look at the imaging studies, we know that people with articular cartilage lesions in their patellofemoral joint, that doesn't predict if that person has patellofemoral pain. It doesn't predict how long they're going to have patellofemoral pain, and it also doesn't predict how severe their patellofemoral pain is. So I think if we can kind of get away from this idea that you're causing harm to your knee, but because you have pain, I think if we can get ahead of that very quickly with our patients, I think our patients will do a lot better from a rehab standpoint.
So let's start to talk about management, because I think that's a nice segue. We've started on the education, and clearly education and talking is going to be one key pillar of a rehab program or of a management program. What are your other, or what's your overarching principles of rehab when you're designing a management program for patellofemoral pain, Rich?
Yeah, exercise therapy is the standard of care for patellofemoral pain, absolutely. Rest is absolutely contraindicated for patellofemoral pain. So, and I should say that absolute rest is absolutely contraindicated. We still need to have some relative rest, potentially at the very beginning when someone's really irritable, but exercise therapy is how someone's going to get better. If someone has patellofemoral pain, and again, this is very kind of common with other musculoskeletal injuries, is that, once they develop patellofemoral pain, you can rest it and your irritability will come down. But once you start going back to activity, that injury is still there and the irritability will just come back. So there has to be a rehab component to this. And that exercise therapy, the foundation there is hip and quadricep strengthening, with quadricep strengthening being perhaps the most important. So any like evidence-based management program for patellofemoral pain should involve quadricep and hip strengthening. And a lot of patients, they may not necessarily tolerate quadricep strengthening initially because they are so irritable. And with those folks, we like to start them off with a very intensive hip strengthening program initially, with the idea that we're going to kind of slowly transition them into some quadricep strengthening so we can start loading that patellofemoral joint. So I think other than that, I think the education thing, you mentioned that a minute ago, I think that patient education is so important, and that's something that we need to be doing that at every session that we have with our patients, is reassuring them that they're not ruining their knees, reassuring them that of course the pain's not great, but that this will be something that will eventually be able to go away. But I think also part of that too is I think we need to provide some realistic expectations for people with patellofemoral pain. I think that this is an injury that has a high recurrence rate, unfortunately, and up to 80% of patients will have a recurrence of patellofemoral pain down the road. And so rather than saying we're treating this injury, I think it's important for us to say, okay, you're probably gonna have to manage this injury. It'll kind of come and go. When you do decide to go out and do too much exercise, more so than what you're used to doing, that overload injury is going to manifest itself with patellofemoral pain. And whereas someone else who has a history of low back pain, if they go out and do too much, they're going to get an irritability in their lumbar spine. So with that said, I think coming up with a successful management program for all of our patients is super important. Finding a few key exercises that this person is just going to have to understand and work through, and try to figure out a way that they can do these exercises in the long term so they can manage this injury, I think is super important there as well.
Yeah, and I think the other thing that we perhaps sometimes forget is the power of reassuring someone that we have got some really strong evidence to back up these interventions. And so we have got some really tangible, good quality stuff that we can offer. So it's not like there's no hope. There's lots of hope, and the good news is that we can really help you out here.
Yeah, absolutely. And when you look at exercise therapy for patellofemoral pain, there's such a huge body of evidence. And when you're looking at that, I mean, none of these papers have shown that exercise therapy is not helpful for patellofemoral pain. So I think that's important for patients to understand that, look, this is something that has been shown to work. Obviously, you have to do it. And I think how you do it matters. And it needs to be progressive in nature. So it needs to kind of increase as that person is recovering from a intensity standpoint. But progressive resistive exercises work for patellofemoral pain. And there are lots of other things that we kind of lump into like adjuncts that might be helpful along the way. Things like knee braces or shoe inserts, taping of the knee, and we can go on and on and on with all the different things that people have tried with patellofemoral pain, and they might help a little bit, but at the end of the day, the common thread there is the exercise therapy.
Cool. So let's talk a little bit about exercise therapy, and particularly the idea of load management and progression, because I'd like to get your best clinical tips on progressing load. I know we talked a little bit before, we touched on this idea of pain and the relationship to loading. So I guess there's going to be questions like, should I stop if my knee hurts while I'm doing these exercises? How do you sort of dose your exercises, and how do you get that program progressing?
Yeah, that would need to be individualized per patient, just like with all things. So we don't want to have kind of a cookbook approach for patients. But I think a really good place to start with most people is that in the early goings, you kind of want to avoid a lot of irritation in the knee. And what we would define as irritation is pain that is increased upon waking the next day after your exercise session, or perhaps pain that has increased later on in the day after you did your exercises. That's a good sign that you've done too much. When you're exercising, generally speaking, we allow patients to have up to 2 out of 10 pain when they're exercising in the early stages. And as we get to know that patient better, we can maybe increase that the whole way up to 3 to 4, maybe even 5 out of 10 when they're doing exercises. And the key part of that is that they're not getting irritated the next day. So we really want to make sure that that's not occurring. So, and again, it goes back to this idea that just because you're experiencing some discomfort doesn't mean that you're causing damage to your knee. It's just that your knee's kind of letting you know that you're loading it. And so, yes, we try not to say, no pain is allowed. And for me, when I look back at how I used to treat, that was one of the things that I did. I used to say, okay, we want to really avoid any sort of pain here. But in hindsight, I think I was really under rehabbing my patients. And so I think we need to make sure that with whatever we're doing with our patients, that we're providing enough stimulus so that they can recover, and making sure that we're not under treating them. And I think a lot of us are starting to recognize that we've kind of had this epidemic of like under rehabbing our patients across a lot of musculoskeletal conditions.
So can we talk a little bit about the progression back to sport? So perhaps thinking of a clinical case of a runner who wants to get back to running, you use the example of 40 Ks a week. So someone who wants to get back to, that's decent mileage. It's not crazy, but it's pretty decent, 40 Ks a week. And then,
Sure.
so let's take that case. And then let's also take a basketball player, for example, with patellofemoral pain. So let's start with the runner first.
Yeah, those are great cases. So running's kind of are really nice. I mean, most sports involve some sort of running. So I think if you understand running biomechanics and runners with anterior knee pain, I think you're going to do well with a lot of athletes. So you want to keep that person running if at all possible. So we try really hard not to tell someone that, look, you need to stop running until this knee pain is better. And the reason for that is that if you ask that person to stop running, their symptoms are probably going to go back down to zero very quickly. And it's going to make you feel very confident as a therapist, and the patient's going to feel very confident too that their knee pain has gone away. But the reality is that you've just removed that irritability, that stimulus. And so rather than having kind of a dichotomous approach to training loads, what we should do is just work on modifying those so we can keep that patient as active as possible. And so for a runner, if they can run, what we like to do is maybe put them on a treadmill and increase that incline a little bit. So maybe a 5% increase in that incline, and that's going to reduce patellofemoral joint loads when they're running. So it's going to shift some of the load up to the hip, and but they're still able to run, and maybe it's not quite the type of running that they want to be doing, but it's a heck of a lot better than no running whatsoever. So we'll do that. We may also do some other things. We may work on their biomechanics a little bit if we find that or feel that that's going to be helpful. And an easy thing to do is ask the runner to increase their running cadence, which seems to reduce patellofemoral joint loads by up to 20%. And we might also ask them to avoid some other, like if they're able to run outside, maybe we keep them running on flat, so we don't have them running a lot of downhills and uphills, uneven surfaces as well. So those are going to be kind of the easy things to do. From a volume standpoint, we want to basically have them run for a duration where their pain doesn't increase. So let's say we have a patient who can run on the treadmill, and they can, when they're running, their pain is 2 out of 10. We want to have them run as long as they can without their pain starting to increase. So once that patient's knee pain starts to increase maybe to like a 3 or a 4, that's a good time for them to stop. So let's, ideally we might have a patient who can run on the treadmill for 30 minutes, and their pain starts to increase after that time point. So we'll still have them run maybe 3-4 times a week, and then we'll make up the rest of the volume with some other type of cross training that does not irritate their knee. So something like cycling or the elliptical trainer, or maybe swimming or something along those lines. And then of course we'll also work in their normal rehabilitation exercises, because if we're not doing that, we're just doing the load management side of things. We're not actually rehabbing that runner. So you need to have both aspects there to have a successful outcome.
So let's talk about the basketball player. What would you do differently to the runner?
Yeah, so the basketball player, I would say the same thing. You're looking at the most irritating part of basketball. And so for running, it would be uphill and downhill running. And for basketball, it's going to be jumping. And so it's really hard to tell a basketball player, don't jump as high. So instead of doing that, what you might do is you might limit playing time. And so maybe rather than have that athlete go the whole way through practice, maybe have them just practice for the first 30 minutes and then, step out of practice and do some rehab exercises or some sort of cross training. Or you may want to limit their overall jumping activity. And maybe a way to do this would be looking at, total number of jumps per practice and trying to limit that. So maybe once they hit that certain number of jumps, and some wearables are really nice now that you can start counting the amount of jumps that an athlete is doing. If you have access to those type of wearables, you can figure out what that number is, and you can track that pretty closely. And then maybe once they hit that number, then have them maybe go do some other drills, like dribbling drills or something along those lines that isn't involving any sort of jumping. But eventually you want to start increasing the number of jumps that athlete is doing, or the amount of time that they're practicing. And so you can do that by maybe initially starting them off again as maybe practicing just 3 times per week. So maybe they're practicing at half their normal load, and then slowly add some minutes on week by week. So it's just a very gradual increase. It's really important to counsel the athletes, particularly when they start feeling better, on their overall training loads, and that they increase their training loads very gradually, because we can't forget that this is how this person got this injury. And a lot of athletes, if they're left up to their own devices, will just do the exact same thing over again. And I think that's one of the reasons why we see such a high rate of recurrence of these overuse knee injuries, such as patellofemoral pain.
Yeah, and perhaps also talking with the coach and trying to get that sort of team involved. Because I think for most of these athletes, the coach is really the one who has a lot of control over the training load. And unfortunately, in a lot of cases where we might want to have a bit more control, reality is that we don't. So I think making sure that communication channel is open is also going to be important.
Yeah, patellofemoral pain is a great time to start working on your free throw shooting. Is maybe a good way to look at it, if you can, kind of motivate the coach to say this is a good time for them to good thing for them to spend their time on.
Yeah, nice tips. I want to come back now just briefly to the quads. You gave some great tips about quad strength and really emphasizing the importance of quad strength. Is there a role here for working on rate of force development or some of the other aspects of muscle function than just the pure strength that we might immediately think of when we think of the quads?
Yeah, well, I think it's worth kind of just stepping back just for a second. We know that heavier rehab results in better outcomes with people with patellofemoral pain. So we need to be working on challenging our athletes to lift more weight. Along those, so I think that's going to be our foundation, is this heavy, slow resistance training, which is almost pretty much exactly the same thing you would see with some sort of patellar tendinopathy or Achilles tendinopathy. So we really want to be doing that, and that's our foundation. But when we look at activities such as running, jumping, cutting, and all those things that are going to be really challenging our athletes, is that there's a high angular velocity component to that too. So that knee is going to be moving very, very quickly. So for us to take an athlete that's been doing very heavy, slow resistance training, and then we throw them back into running or throw them back into jumping, that's a huge kind of leap, if you will, between something that's very slow to something that's incredibly fast. So we're talking, for the knee, you're talking angular velocities of 300 to 400 degrees per second, which is way, way faster than what we would be doing our normal rehab exercises. So we should try to bridge that gap with some sort of power exercise. And if you can, doing some things such as just, very, very rapid, very quick bridges off of a table, I think would be a great way of doing them as fast as you can. Perhaps doing some knee extensions that are done very quickly, I think would also be a great way. But one of the things that we do a lot is we use plyometrics a lot with our athletes. And I really like plyometrics a lot, because plyometrics take that very high load that we see with our heavy slow resistance training, and it layers on this high angular velocity. So we've got this nice gradual increase. So now I've got this high angular velocity, but we don't have that high cumulative load that we would see if you're going to go out and go running, for instance. So a typical, let's say you go out and run 10 kilometers. For me, when I run 10 kilometers, I get about 10,000 foot strikes per 10,000 kilometers. And so when you think about that, or 10,000 meters. And so when you think about that, that's 10,000 loading cycles. And the nice thing about doing some sort of plyometric where you are working on force development is you might only do 3 sets of 10, and that angular velocity is going to be the same. And then that's going to make that increment very much smaller with that person going back to the running that they need to be doing or the jumping that they need to be doing. So yeah, I would really recommend trying to do that. We've been doing that more and more with our athletes. And I see that, I think it's most useful for, again, the jumping athlete, sprinters, runners who are running downhill a lot. And I know Christian Barton, who's a good friend and colleague of mine, they just published a recent paper where they found that integrating some power training into athletes who have patellofemoral pain ends up resulting in better outcomes. So yeah, I think if you're not doing that, I think it's certainly something to consider.
What are your favorite plyometrics exercises, Rich?
Oh yeah, so that's a great question. So we usually use a box, and so I'll first start off with the person with their foot on the box, and I'll have them work on power generation, where they're just jumping straight up in the air, and so they've got one foot on the box and one foot on the ground, and then they're just leaping up in the air. So they're working on the power generation side of things. Once they're doing okay with that, then we'll transition into some power absorption, and so we'll have them standing on the box and basically just doing a kind of a drop jump, and they just land and just stick the landing, so they're just absorbing the load. And then the next progression from that would be they're coming off the box, they're absorbing the load, and they're immediately rebounding, doing some sort of counter movement jump.
And is
So
this single leg or bilateral?
yeah, so someone who's a little bit more irritable, we might start off with doing bilateral, and then we'll progress them into to single leg. So when we have our, in Montana, we have a lot of mountain runners and trail runners, and so for them, they have to run down very steep trails. So we'll add some external resistance to have them hold on to some dumbbells to add that even more load, and that seems to be that really nice kind of bridge to being able to get them back to doing some downhill running.
Nice. And I think the other thing that some athletes find when they first start doing plyometrics is they get really sore because of the eccentric control. How much are you talking with them about that? How much of the sort of education bit is coming into, we're doing this and you might feel these sorts of things when you start doing plyometrics?
Yeah, yeah, definitely. I think with all those things, like anytime we make some sort of transition, we're going to spend some time and chatting with them about the fact that this is a change, so you might experience some late onset muscle soreness. That's good. And in fact, that's a great thing. That's what we kind of want because we want to be challenging the system. So we actually see that kind of as more of a desirable thing than something that they need to be really worried about.
Can we talk a little bit about VMO training as well? And
Oh yeah.
Does VMO training fit into this, or what are your thoughts on VMO training?
Yeah, so it used to be that we thought that VMO training was a large component of patellofemoral pain rehabilitation, but now we know that like if you're strengthening one part of your quadriceps, you're strengthening all parts of your quadriceps. So we don't tend to look at VMO type exercises versus quadricep strengthening exercises. If you're strengthening your quadriceps, you're strengthening your VMO, and you're also strengthening like your vastus lateralis. So we don't really split things up. And in fact, when you look at the way that we handled the literature for our clinical practice guideline, we took all the VMO training literature and we combined it with our generalized quadricep strengthening literature when we were doing that, because we didn't see any difference when we're looking at the literature at all. So if you're doing that now, I think it's it's great that you're thinking at that level, but it's probably not necessary. I think that the more important thing is to think about how you can get more load on your athlete from a resistance training standpoint.
Great, and you've given some great examples of that. So I want to move us to talking about biomechanics a little bit more. So we've addressed the strength side. Let's talk a little bit about biomechanics and assessing biomechanics to start with, and then what you do with that. So I'd like you to sort of walk us through your thoughts on, how much you focus on assessing biomechanics, how much is that driving the decisions that you're making in the clinic?
Yeah, I think I've kind of really evolved here. I used to be, when I came out with my PhD in 2011, I used to think that, faulty biomechanics was the underlying reason why everybody got patellofemoral pain. And now more so, I definitely feel that it's, and you look at the literature too, it's suggesting that it's this relative overuse injury or overload injury. And so the biomechanics is probably what's determining where that injury is going to show up. So if you have maybe if you go into a lot of hip adduction where your knees kind of caving in, and you do when you're running or when you're walking downhill, if you increase your training volume, you may end up getting some sort of knee injury. If you're a forefoot striker, on the other hand, and you decide to do too much, you may get an Achilles tendon injury. And so the biomechanics maybe is just helping the injury kind of figure out where it's going to manifest itself from a relative overload standpoint. I still look at it. I definitely do. And I think, though, when it comes to altering an athlete's biomechanics, I try to do it only when necessary. And so it looks like, now if you asked me to guess, I would say maybe 20% of the athletes, we might do some sort of movement retraining with them. And so whenever we do that, though, of course, if it's a running athlete, everybody gets a running evaluation. So we do a very simple clinical gait analysis, and we take a look at that. And we see if there's any sort of mechanic that we know may increase load on the patellofemoral joint. So for instance, with running, we know that if someone is taking a very long stride, that's going to increase load on the patellofemoral joint. We know that if you're taking a long stride versus someone who's taking a shorter stride, that's going to increase the load on the patellofemoral joint by up to 25 to 30%. So if someone comes in and they have patellofemoral pain, that's a super easy thing to change. Just ask them to increase their cadence, and we use a wearable to do that. But from a clinical standpoint, the way that looks is if you see that the lower leg or your tibia, that tibia is really kind of inclined, out in front of the person at foot strike, that's a good sign that that person is overstriding. If we're seeing that tibia, of course your femur is coming down. If that tibia is much more vertical, we don't get too excited about changing a runner's step rate, or they're having them take a shorter step. The other mechanic that we see a lot is kind of, I think, what a lot of people will call dynamic valgus. And so with that, we see increased hip adduction, where that thigh is kind of drifting in the frontal plane. We see that mechanic more so in women than males. We still see it also in males too. But for me, in order for me to change something, any sort of biomechanic, I would take a look at it, and then I would ask them to change it. And then I'd have them still do that same task. So if they're running, I'd ask them to try to work on controlling that a little bit. And if that reduces their pain, fantastic. And that means that we're probably going to use that somewhat in their rehabilitation. If it doesn't change their mechanics at all, we don't get too excited about it. We just go, okay, let's just move on and go on to something else. So I think that, the person has to have the coordination to be able to make the change, and then the change has to result in some sort of symptom modification. And if those two criteria are satisfied, then we might use that in their rehabilitation.
Great. Can I get you to walk us through what your clinical gait assessment looks like? Is it just on the treadmill? Where do you have cameras set up? Is it a visual? What does that look like?
Yeah, we have of course, I'm sitting in our gait lab actually right now. We have a 8-camera motion capture system, and we have a $100,000 treadmill that measures forces and all that great stuff. And we use the little reflective markers that I think most people are familiar with from motion capture studies. But when we do a clinical gait analysis, we actually use none of that technology at all. We just use a high-speed camera, and if you want, you can just use your phone. Pretty much any smartphone these days has some sort of high-speed camera function. So that's pretty much all I use. And with that, I'll take the person running. We know that for them to settle into their normal running mechanics, it takes them typically about 3 to 5 minutes to do so. So we get them up on the treadmill, let them get accommodated to the treadmill, usually talk to them about, like the weather and how their day is going and all that stuff. And then we'll go around and collect some data or collect some video, and I'll take a side view, and I'll take a view from the rear, and then I'll take a view from the other side too. And I don't take video for very long, and then we'll kind of upload it into our computer and then take a good look at it. We keep it pretty basic. I think the simpler you can keep your clinical gait analysis, the better. So if it's not running that's bothering them, if it's jumping, we would do the same thing. We might have them kind of practice like a layup or something or if they're a volleyball player, have them do some sort of like a spike jump and see how they land, and take a look at their mechanics there, and see if there's something that we can attribute to a higher or increased load on their patellofemoral joint. I think it's important to keep in mind, though, that the biomechanics, while those things it's very nice and very interesting, it's the increase in their training load that caused their injury. And you have to come back to that. So if you're going to modify a person's biomechanics, that's great. And I would consider that more of an adjunct. So for me, I used to think of that as like a primary and like some sort of primary intervention. But now I see it as like there's an adjunct there that if I have that person increase their running cadence and it reduces their knee pain, I can get them to run a little bit longer, or it might reduce their overall irritability of their knee. That means I can get them onto the knee extension machine or the leg press and get them to lift more weight. And so it always comes back to, how can I get more load on this athlete? How can I get them to lift more weight? How can I get them to maybe run a little bit further and get their function back? People don't come to see us as physiotherapists or physical therapists to fix their biomechanics. They come to get their knee pain fixed.
Nice. So I love the really concrete clinical messages, Rich. I want to come back to a couple of the common things that I hear people talking about when they talk about running assessment and biomechanics. And hopefully you can help us debunk stuff or help us sort of figure out what we should focus on if we are trying to change gait biomechanics. One thing that I think has had a lot of attention is foot strike pattern and changing foot strike. And you talked about changing cadence. Changing foot strike to prevent injury, yes or no?
Yeah, so a really nice paper just came out. I think it came out of Brazil, and they found that being a forefoot striker or a rear foot striker didn't seem to affect your risk of developing patellofemoral pain. So it doesn't seem to make as much difference. And now when if you are a rear foot striker and you change and you have knee pain and you change to being a forefoot striker, that's going to reduce your load on your knee quite a bit. But of course, you're going to be increasing your load somewhere else, and that's going to be your plantar flexors and your Achilles tendon. So you definitely run the risk of developing some sort of plantar flexor or foot injury when you make that change. So I tend not to do that. I tend not to encourage runners or prescribe some sort of foot strike change in runners, because I think that risk is too much. And when you look at the amount of reduction in patellofemoral joint loads when you do a switch to a forefoot strike, it's just about the same as if you increase their running cadence by about 5 to 10%. And when you increase your cadence, it just kind of reduces the overall load on the system, versus when you're changed to a forefoot strike, you're just shifting the load around and you're going to really concentrate that on the plantar flexor. So again, I come back to what's going to be the least risky way for me to reduce patellofemoral joint loading, and running cadence is the easiest thing to do. I think most clinicians can do that really quite easily.
And tips for wearables or any sorts of ways of monitoring cadence? Because I mean, it's all great, go, run or change your cadence by 5%, but how do I know what 5% is?
Yeah, how do you know you're doing that?
And I can't count my steps.
Well, so there are lots of different ways to do this, and I've got my favorites. But you might hear someone say like use a metronome, and so I think using a metronome and increasing that the beats per minute by a certain amount kind of makes sense in the clinic, and it might make sense for a couple minutes, but it's pretty annoying, and the runner is going to tune that out very, very quickly, and it's not really going to be feasible. So they're not going to do that. So I would say that that's probably not the best idea. Some people might use like a music app, where you can punch in like the beats per minute that you want, and that might work really, really well if you're a fan of Daft Punk. But if you're not, that might not be so helpful. So the music thing, it might be okay, but those are cues. Those are telling you how to change it. They're not actually telling you how you're doing. Like, how are you hitting your target? Because there's no feedback. You need the feedback component. So we've got a cue, which is, okay, I want you to increase your cadence, and here's your target. And then you need to have some sort of feedback saying, okay, this is where we should be. This is what you're doing. Do what you need to do to get it to here. And so there needs to be that feedback component. And that's where wearables are super handy. You don't have to get too fancy with that. So I've just got a regular Garmin running watch, and pretty much any running watch that counts your steps will also give you real-time feedback on your running cadence. And that's a really easy thing to do. And if anybody who's listening right now, if they want like a step-by-step guide on how to get your Garmin to show your steps per minute, just email me and I'll be happy to, or direct message me on Twitter or something like that. I'll be happy to share that document with you. It's a super easy thing to do. And most runners, I think, like we just wrote Izzy Moore, who's a fantastic researcher in the UK. We just wrote a paper, and I think we saw that 93% of all recreational runners have some sort of GPS running watch that they use. So the majority of people coming in are going to be able to give feedback. Now, if they don't, you can also use your smartphone, and there are some nice apps that will, of course, you have to carry your smartphone with you, and you have to use like an arm sleeve, and there's an accelerometer which will measure how much it's swinging, and that'll calculate your step rate. So there are a couple of really nice apps. A really inexpensive one is called Run Cadence. I think you can get that for maybe $5-6 from iTunes. So all those will give you both your cadence and also give you feedback on that.
Fantastic. And I should also point out that this live stream is not sponsored by Garmin.
No, it's not. No, all the other ones will do that too, like Polar and what else? Sunto will also give you feedback on cadence. So yeah, lots of ones will do that.
Now, one of the other areas is verbal cueing. So have you got some tips to share with folks for verbal cues for running cadence or biomechanics?
Yeah, boy, this is kind of a bit of a motor learning question, and it's a great one. I think that earlier we talked about kind of one rule of thumb, which I think a lot of therapists maybe under rehab their runners. I think another rule of thumb is I think a lot of therapists over cue their runners and over cue athletes, and we just tell them too much. And that's while our intentions are very good, it actually it's hindering that person's learning. And we know that people learn by making errors, and they learn through experiential learning. So by experiencing something and seeing if it's working for them or if it isn't. So when it comes to running cadence, I don't tell them what to do. I just say, okay, we might stand there, I might hold their watch up in front of them while they're running on the treadmill or something. We use a foot pod so it transmits the signal up to their Garmin. And I say, all right, so you're running at 172 steps per minute. We need to get that up to 184. Make it happen. And I don't tell them what to do. I might say, just be a little bit lighter on your feet. But I don't tell them things like, okay, I want you to land with your knee more flexed, or I want you to land with your foot flatter. They need to figure that out for themselves. And the reason why they need to figure that out for themselves is because every runner is going to have their own individualized kind of solution to that problem. And that solution is going to fit that person's anatomy, their injury history, their coordination patterns, and so forth. So we don't tend to cue them very much. So that's the easy one to do. When it comes to, let's say a runner is running and they have a lot of hip adduction, and if that's something that we want to cue them out of, or maybe they're jumping and they're landing with a lot of hip adduction, so they're kind of going into this dynamic valgus. What we might do there is, it used to be, I used to tell that person to squeeze your glutes and increase the distance between your knees. But one of the things I found is that, well, after doing this for a while, I started asking, the athletes, I say, okay, so this is what I'm telling you to do. What are you actually thinking about? And none of them were actually thinking about what I asked them to think about, because it didn't work for them and it was too hard. So I started really recording and writing down what athletes were doing. And one of the things that seemed to come out often was that runners were talking about, and also jumping athletes were talking about pushing their knees toward the walls and pushing their legs out, or maybe even pushing the walls away, which would be kind of more of a, rather moving from this internal focus of attention of squeeze your glutes to more of this external focus of attention of, manipulate an object. So push the walls away. And so the way we do that now is I put one of our motion capture markers or a piece of tape on the outside of the knee, and I tell them, just push the tape or push the marker out. And so that's how we get someone from going into so much hip adduction.
Great. Can I bring us back to quads and hips? This is a nice segue, because one thing I'm wondering about is why so much emphasis on the quads. We used to get a lot of emphasis on the hip and strengthening the glutes. So what's the shift, and why? Help me out, please.
Well, yeah, I mean, I think, let me go back for a minute and say that we know that quadricep strengthening is effective for patellofemoral pain, but we know that quadricep plus hip strengthening is even more effective. So you should really be doing both of them. So I want to be clear about that. We used to think that, well, two things. One, we used to think that if you had weak hips, so weak glute medius, glute max, that was going to increase your risk of developing patellofemoral pain. But now we have really nice research that's showing that weak hips doesn't cause patellofemoral pain. The patellofemoral pain actually causes weak hips. And there seems to be this strong inhibitory component to pain. If you have pain in your knee, it's going to make your quadriceps not as strong, so you're not going to be able to exert as much force. And also for those posterior lateral hip muscles, your gluteus medius and your gluteus maximus. So we still want to really strengthen those muscles. And it does seem that we see about a 44 to 80% greater improvement in pain if you add hip strengthening to a quadricep strengthening program for people with patellofemoral pain. The problem is we don't know why. We don't really understand why. And to me, that's super fascinating, because we know that if you strengthen, let's say you have that athlete who does have that, who goes into a lot of hip adduction, you can strengthen that person's hips all you want. Their hip adduction is not going to change. And that's because that's a motor control issue. It's not a strength issue. That doesn't mean that someone moves like that. They may have some weakness. But that's not the reason why they move that way. They're just not perhaps using their strength appropriately. So it doesn't seem to change their biomechanics by doing a lot of hip strengthening. We don't really know why. And it probably has something to do with it from a central pain processing standpoint. But yeah, it's a good question. But we know that if you have a hip strengthening program, if you add hip strengthening to a quadricep strengthening program, that not only do you get better outcomes than if you just do quadricep strengthening alone in the short term, but we also even see that the whole way out to a year after rehabilitation. So it seems to be a real lasting benefit to adding the hip strengthening.
Yeah, wow. And again, really powerful thing, relatively easy thing to do in the clinic, and then hopefully have some really good benefits. Can I ask a very specific question that's come through on social media? If someone is so irritable that they can't even walk, where would you start with designing a management program?
I would try to be loading around that knee as much as possible. So I would maybe be doing some plantar flexor strengthening and also some hip strengthening with that person, just so we can get some load on that system. And so, and then eventually as their irritability goes down, get some load on the quadriceps. And so if they're having so much pain that they can't walk, well, first off, you want to make sure you're not missing something that's really important. So that might be a good time to get some imaging, just to rule out the red flags. Imaging in and of itself is not helpful with diagnosing patellofemoral pain, as we were kind of talking about earlier. But I think if someone has so much pain that they can't walk, you need to get them active. Rest is not going to make this knee better. And so if that means something, when we think about things that have some load on the patellofemoral joint, but the load is quite low, would be things like cycling and like maybe some aquatic therapy would be very helpful. But you really need to get this person moving as quickly as possible.
I wonder, any evidence for blood flow restriction training that's starting to come particularly into the ACL and the cartilage world. Do we know anything about blood flow restriction? Is that something that you might try?
Yeah, so Lachlan Giles, and he got his PhD at La Trobe University, had an RCT that came out a couple years ago, and they looked at blood flow restriction training for patellofemoral pain. And what they found is that they had two groups. So one group just got standard quadricep strengthening, another group got blood flow restriction training and high repetition strength, quadricep strengthening. So they're doing 30, 40 repetitions at a very low amount of resistance, but they've got this blood flow restriction training on there, or going at the same time. And what they found was that if you got the BFR training, your quadricep strength increased at a greater rate than people who just went through normal normal quadricep strengthening, but they didn't have better outcomes. Their pain and function were the same. So it seems like that might be very beneficial for someone who is particularly very irritable, maybe perhaps in the early stages of patellofemoral pain rehabilitation. But it's not going to be something that's going to cause like this dramatically improved outcome over normal quadricep strengthening. So I would consider it not to be, it's a nice thing to have if you have access to it. It's not essential, and it will improve the patient's strength, but not their function.
Now, Rich, we talked up earlier in the hour about psychological aspect of managing patellofemoral pain, but it was more in the context of measuring, and you talked about using the Tampa scale for kinesiophobia. Can we touch briefly in the last few minutes that we've got to bring us up to the top of the hour about how you might incorporate some of the psychological aspect into designing your management program?
Yeah, I think, that's a good question. That's a really good question, actually. So I would, as you're progressing load on that person, it needs to be more than just you're adding more plates on your knee extension machine. And so you want to slowly progress that patient and into things that are going to be more and more irritable for that patient. So perhaps maybe you're doing some heavy squats with your patient, but you're only going through a restricted range of motion. You slowly want to be increasing the range of motion so that they're going into more and more areas where they associate that with pain in the past. And I think it's really important for a patient to experience some discomfort during their rehabilitation, particularly because it's a very controlled environment. And what it does is it helps the patient understand that, look, they can experience some pain, and then it's not such a big deal, and that they might get over it very quickly. It's not this thing that's going to cause them a lot of problems to get up and down the stairs the next day. So yeah, I think as soon as you can, maybe not in the early stages when you're still trying to win the trust of a patient, I don't think it's important to go in and start, having them do very painful exercises. But I do think you need to make that part of your rehabilitation plan. And if you're not, I think that patient is eventually going to experience some patellofemoral pain when they go back to doing their normal activities. And that can be very frightening for them if they never experienced it during their rehabilitation. And I think the whole time reassuring them that, look, you're not ruining your knees. This is not ruining your articular cartilage. You're not getting this pain because you have bad alignment, or you have, or you're tall, or all the things that we know don't seem to really relate to patellofemoral pain. I think anything we can do that can be reassuring, I think is going to be super important there.
Yeah, and I think Tim Gabbett, among many others who have done a lot of great work in the load management space, would say that it's about building a robust and a resilient athlete. And part of that is going to be about self-management side of it. Part of it is going to be coaching the person through that, yes, it might hurt a bit. That's okay. Pain does not always equal tissue damage and all of those core principles.
Yeah, if I can just add something in there, going back to Tim's work, is I think it's going to be very instructive, and that's that increasing the overall activity level of the athlete. And we know one of the things we know with people that have patellofemoral pain, they have about 40% lower activity levels of someone who doesn't have patellofemoral pain. So going back to the wearable thing, if you can use somebody who has if they have a step counter, use it to kind of track how much they're walking. And I think they might be shocked at how little they're walking when they have patellofemoral pain, and try to get those step counts up and make that part of your rehab program so that they're becoming more and more active, and so they become much more of a robust individual, more so than just doing pure quad strengthening.
Nice. Rich, I think we might end our live stream today, but there's one really important question that I must ask. Your Twitter profile says that Beastie Boys is playing in the lab. What's playing when you run and when you ride your bike?
Oh gosh, that's a good question. Well, I mentioned Daft Punk. I tend to listen to Daft Punk quite a bit, so I'm a little bit partial to that. So yeah, I think that's a good answer there. We'll stick with that.
Nice. That's a very good answer.